Stillman and the University of Ghana, the University of Cape Coast, and Central University in Ghana. And our guest speaker is actually from the University of Alabama, Birmingham, part of the, he is from the Division of Preventive Medicine and General Internal Medicine. And so we have a system here in Alabama. Our universities have four universities that are part of our system. And so we are in a town in Tuscaloosa, about an hour south of Birmingham, where Dr. Durant is from. And so as we're hoping to expand our partnerships, we would love to include the University of Alabama in Birmingham. And we know that our College of Community Health Sciences also has links that we've heard about today with UAB and the medical school. And we also heard today from Dr. Warwick at Stillman that she has some interest in maybe expanding partnerships to other universities. She mentioned Howard at one point. So we hope to, again, expand and create greater collaboration relationships with other universities as we move forward. So again, thank you all for returning and coming back for this second part. So today, because we are dealing with the challenges of a global pandemic, in Ghana, here in the United States, we've heard a little bit about how universities are handling this. We thought it would be wonderful and appropriate to have our guest speaker, Dr. Durant, Reagan Durant, who is an MD and PH, again, from the Division of Preventive Medicine at the University of Alabama in Birmingham, to talk about COVID-19 and health disparities. UAB has been a leader in helping our university system and the medical school deal with the COVID crisis and helping us understand how to do screenings and education about social distancing and all those kinds of things. Dr. Durant, as I mentioned, is an associate professor of medicine in the University of Alabama, Birmingham. And he is originally from Alabama, so this is good, and completed his bachelor's degree at Howard University, so another connection there. Completed his medical education at Johns Hopkins University School of Medicine in Baltimore. He did his residency training in internal medicine at Duke University Medical Center in Durham, and he went on to complete a research fellowship at Beth Israel Deacon's Medical Center in the Harvard Medical School in Boston. During his fellowship, he received a master's in public health, and so today his expertise deals with chronic diseases and using public health. And we are, as a group with the Ghana program, Dr. Durant, exploring the social determinants of health. That's one of the themes in looking at a variety of social determinants of health. During the fellowship, he also received his, as I mentioned, master's degree in public health from the Harvard School of Public Health. He came back to Alabama, thank you, and joined the faculty in the Division of Preventive Medicine at UAB. So his research is focused on assessing the impact of psychosocial factors such as social support on chronic disease outcomes in minority populations, with an eye toward developing tailored community-based interventions. Dr. Durant also studies multi-level barriers to the recruitment of minorities into clinical trials to inform the development of system-level and behavioral interventions to increase diversity in research study populations. So thank you, Dr. Durant, for being here. He's going to talk about COVID-19 and health disparities. So he's got great expertise. And so we have Dr. Durant, as I mentioned, representatives from 3 of our partner universities in Ghana, as well as Stillman University. So are you ready, Dr. Durant? And what I'll do is I'll share the screen. And then when you want me to, I will put myself on mute and make sure everyone else is muted. And then when you want me to change the slides, just let me know. Sound good?
Thank you so much, Dean Pulowski, and thank you both, you and Dr. Payne Foster, for the invitation. I look forward to addressing this international group. And hopefully it will spark some fruitful discussion at the end as well. So next slide. So this is just an overview of the presentation, and will give you some sense of what we're going to talk about today. Just a very brief overview of COVID-19. Thinking for better or for worse, at this point in 2020, most of us are up to speed on COVID-19. So I'll just cover this briefly. And then I want to talk about health disparities through the lens of COVID-19, with particular focus here in the US, and then even more granularly here in Alabama, and even in some counties here in Alabama. I think that will elucidate some important lessons, not only for COVID-19, but in the broader discussion of health disparities. And then we'll spend some time talking about next steps. So I think as we all try to do in this evolution of our study in health disparities, we try not to stop at pointing out problems, but then really to try to give some time and attention to what can be done about some of the problems that we highlight. So I'll try to do that in this talk as well. So next slide. So first, we'll start with the overview. Next slide. This perhaps is the most widely disseminated model of a viral particle probably in the history of mankind. I think when we see this, we all know what it looks like. It is indeed a model of COVID-19, the novel coronavirus, otherwise known as COVID-19. Just some very basic facts about COVID-19. It's an RNA virus. It's in the same family of viruses that some of which cause more common conditions like the common cold, like alpha coronavirus and beta coronavirus. And it's also closely related to a number of animal coronaviruses, some of which we have had encounters with before in much smaller scale epidemics, but significant epidemics nonetheless. SARS being the first roughly 20 years ago, not quite 20 years ago. And then the MERS epidemic as well, that's ongoing, but it's been far overshadowed by COVID-19, which is indicated in the last bullet. Next slide. So the clinical symptoms, again, I think we're all familiar with here, and I'm not going to spend a lot of time here. The virus is spread primarily through respiratory droplets. The tricky thing with COVID, as we all know, is that it can be spread by those who are both symptomatic, and then others who are either asymptomatic or what's called pre-symptomatic. So infected, but haven't yet developed symptoms, they still are at risk for spreading the disease. And that's what makes the spread so high at times, and makes taking precautions so difficult because it's not as simple as just identifying those persons with symptoms. The symptoms can appear up to 2 weeks after an exposure, and the mean incubation period is about 5 days. And the most common symptoms include fever, cough, and chest tightness. Most people have a mild clinical course, but the case fatality rate is about 3 to 4%. And I think as we've all read and heard in the news and perhaps even in the scientific press, this is roughly twice the, a roughly 10-fold higher case fatality rate compared to influenza, which is sort of our reference point for widespread viral illnesses of this nature. The most dangerous aspect of symptomatic COVID-19 is a cytokine storm, which can occur 5 to 10 days after onset, and this leads to acute respiratory distress syndrome, thromboemboli, and even death. And so many of the people that are suffering in the hospital and fighting for their lives, quite frankly, in the hospital are doing so in part because of this cytokine storm phenomenon. Next slide. And here's just a list of the common symptoms. They're depicted here. I'm not going to go through them, but these are the 7 symptoms that are being asked probably of all of us, sometimes on a daily basis, certainly on a regular basis. And this is what we're looking for when we are trying to screen for COVID-19. Next slide. So this slide just looks at COVID cases by age. And you can see here that, and this is here in the US, the number of cases on the y-axis, And then on the x-axis, strata defined by age, starting with the 0 to 17 on the far left, and then going all the way to 75 and older on the far right. As you can see, the majority of cases actually occur in young people approaching and up to the lower end of middle age, what we would define as middle age, so 18 to 44. And then a close second is those middle age to the lower end of what we would consider elderly here in this country. Though we hear a lot about the vulnerability of the elderly here in the US and globally, you can see that actually smaller numbers are, in terms of just cases, impact those 65 and older. Next slide. So the predictors of severe illness, because one of the things that every country and every state and community and other sort of categories of areas where there are efforts ongoing to fight COVID-19 has been what predicts who's going to become severely ill. We know now that age predicts severe illness, and I think we've known that from a very early point. At probably 3 months into the pandemic, around June, one novel factor was African-American race here in the US, was actually identified as an independent risk factor. It's unclear why. We'll talk about some of those reasons why, but it's a predictor of severe illness, even when controlling for other factors like comorbidities and certain social factors. Male gender, so men just tend to be more prone to severe illness. And then these comorbidities that are listed here, many of them are some of the more prevalent chronic diseases that we see here in the US: chronic kidney disease, chronic obstructive pulmonary disease, or emphysema, as it's more commonly known, type 2 diabetes down there at the bottom, and certainly obesity, which we see in striking numbers here in the US, and particularly here in Alabama as well. Next slide. So I'm going to drill down a little bit closer to home and look at sort of the timeline of COVID cases in Alabama. And what this graph represents is the timeline from early February. And you can see the box there on the toward the left. It shows when there were 0 cases in early or mid-March, excuse me. And on the y-axis, you have newly confirmed cases. And then the x-axis, the monthly marks to demonstrate the passage of time from February through really up until, I think yesterday. I think this goes all the way to September 21st. And the yellow line represents the number of new cases, newly confirmed cases for each day. So you can see that we started off slowly, like most places, and then we reached a certain level in mid to late July, where the daily rate of cases peaked. And it peaked at almost 2,000 cases a day. That number has since dropped. And now on September 21st, it was about 800 new cases daily. And that contributed to over 145,000 cumulative cases over the course of the pandemic. So that's just here in the state of Alabama, over 145,000 cases. The dots at the top actually represent sort of policy decisions that occurred at various junctures as well. And we can see the extent to which guesses can be made. It's hard to definitively prove causality, but certainly we can make some assumptions perhaps about how those may be related to these spikes. So the brown dots represent more restrictive measures like closure of businesses, and then the green dots represent easing of those restrictions. So you can see early on there were a number of things that were closed, and then around the beginning of May, extending through the month, There were businesses that were allowed to reopen with some restrictions, but reopen nonetheless. And then in late July, when cases started rising, there were additional restrictions implemented. One of them, and they all have these names like Safer at Home, but one of them that was implemented in late July was the statewide mask order. And that continues to be in effect, wearing masks in public places. And again, we can only make assumptions here, but it does seem that we had a bit of a increase in restrictions, some reopening or ease of those restrictions. Our case rate went up, then we added more restrictions and case rate has gone down. Again, I think we'll spend quite a bit of time trying to determine whether or not those are truly real associations or not. Next slide. This is just a parallel slide looking at deaths in Alabama. I'm not going to spend a lot of time here. It's essentially the same framing as the previous slide, except this time instead of cases, we're looking at deaths. And on the y-axis, you see the number of deaths. And then again, on the x-axis, you see sort of time marching along between March and this one ends, I think, as of Saturday, the 19th. And you can see an almost parallel pattern where we started off very low, sort of plateaued at a low to moderate level, and then spiked in July, leading into August, dropped down a bit, but not dropped down to those May-April levels where we started. And that almost correlates with what we saw with number of cases as well. And as of Saturday, that's represented 9 deaths per day, but you can see we peaked at almost 30 deaths per day in late July, and over 2,400 cumulative deaths here in the state of Alabama. Next slide. So this just looks at case tracking, and this shows a number of some similar data, but shows a number of deaths as well as a number of, and this is sort of a snapshot from late June, the number of recovered, and that's what I want to draw your attention to on the far right. So obviously we do have deaths, but we do have a number of individuals that are diagnosed and then recover. This is probably an incomplete number because the number recovered are only measured oftentimes among those who are hospitalized. We don't have a great way of keeping track of recovered persons who have been diagnosed but don't require hospitalization. But this certainly reflects the number recovered from those that needed to be hospitalized. Next slide. So now let's talk a little bit about health disparities through the lens of COVID-19. Next slide. So just want to put up a couple of definitions of health disparities. I'm sure given the work that you all do, that you all are familiar and have your own definitions that you formulated via experience, and you're probably familiar with these, but I think this just helps to frame our discussion about disparities moving forward. The Institute of Medicine, in the seminal work on equal treatment in 2003, described disparities in healthcare as racial or ethnic differences in quality of healthcare that are not due to access-related factors of clinical needs, preferences, and appropriateness of intervention. The working definition from the CDC in 2007 took on a framing more of health equity and really described it as a fair distribution of health determinants, outcomes, and resources within and between segments of the population, regardless of social standing. So here we have definitions that really do cover the idea that certainly we're talking about differences, but we're trying to focus on differences that are not necessarily due to clinical needs or preferences. And then we're also looking at potential causes of those differences that occur regardless of social standing of individual groups. Next slide. So let's look at on this slide, COVID-19 cases by age, race, and ethnicity. So this is a slide actually from the New York Times back in July. One interesting thing with COVID-19 is that I think as scientists and as healthcare providers, we sometimes, and this is an aside, we are a little bit skeptical of scientific data that's published in the lay press, but I think COVID-19 has been an interesting phenomenon in which there's been opportunity to catch up, and the lay press has actually been the source, a primary source in some cases, of very good and reliable data on the pandemic. This is an example of that. This is looking at case rates per 10,000 people stratified by age and race. And you can see what I want to draw your attention to is that Blacks and Latinos in the US are contracting COVID-19 at rates twice that of whites. And this is true at pretty much every decade of life. So you can see the scale for whites in the greenish bars is 50. And then you can see the scale for Blacks and Latinos is that bar the dotted line represents 100. So really you're looking at almost or over a twofold increase in the case rate for Blacks and Latinos compared to whites. And again, this is at every decade of life, which is quite striking. Next slide. And so not only are African Americans and Latinos contracting COVID-19 more frequently, they're also being hospitalized more frequently than whites. And so these are age-adjusted COVID-19 hospitalization rates by race and ethnicity, looking at the time window from March through July 2020. And so you can see whites there and this is per 100,000 people at 53. And then you can see African Americans literally almost 5 times, African Americans and Hispanics, not quite, but almost 5 times the hospitalization rate compared to whites. And Asian and Pacific Islanders are more comparable to whites, but then we look at American Indians and Alaskan Natives, and they're at the highest, greater than a 5-fold difference in hospitalization rates compared to whites. So again, incredibly stark differences in who's becoming most severely ill once they contract COVID-19. Next slide. So one interesting thing when we look at hospitalization rates, there sometimes is the immediate assumption perhaps that maybe the groups that are being hospitalized more don't have access to outpatient care, and for that reason they rely more on emergency departments or can't call a personal doctor and get tested or treated in an ambulatory care setting, and instead rely on hospitals or emergency departments for their care. This slide sort of debunks that as a potential explanation for the increased hospitalization rate. So this is looking at cases and hospitalization rates among Medicare beneficiaries. So for our guest from Ghana, you may be aware that Medicare is our, for lack of a better word, national health insurance program for persons over the age at 65 or older. So we pay into it when we work, and then when we reach 65, we become eligible for Medicare, and it covers large portions of both inpatient care, and for those who opt in for relatively nominal premium basic outpatient care as well. And then there are other layers that individuals can pay more to receive higher coverage or coverage is broader in scope. But the bottom line is these are individuals who have relatively good access. And even looking at this group, we still see the same disparity in cases and then as well in hospitalization. So you can see, looking at whites who had white Medicare beneficiaries who had 712 cases per 100,000. You can see that numbers doubled when you look at African Americans, and not quite, but almost doubled among Hispanics as well. And then when you look at hospitalization rates, again, 175 among whites per 100,000. And then among African Americans, that number is more than tripled and more than doubled among Latinos. And when we look at American Indians or Alaskan Natives, though theirs among Medicare beneficiaries is not as high as was all comers in the prior slide, they still have significantly higher rates of both cases and hospitalizations than whites. So again, the take-home message here is that even when we theoretically equalize access, we still see these higher hospitalization rates among certain racial and ethnic groups, suggesting that it's not just a matter of access. And we'll talk about some of those other reasons that could be at play later on in the talk. Next slide. So we've looked at case rates and hospitalization rates, and unfortunately that leads us to the moribund slide of mortality rates. And not surprisingly, just like the other measures, we find that there are disparities here as well. And non-whites across the board, with the exception of Asians, tend to have higher mortality rates. So this is data from the Kaiser Family Foundation, looking at mortality rates by race and ethnicity as of August 4th, 2020. And again, these are rates per 100,000 people. We can see whites at 36 per 100,000, African Americans at double the rate, Hispanics at a higher rate, American Indians or Alaskan Natives, as well as Native Hawaiians or other Pacific Islanders, also higher rates of death from COVID-19. So again, looking at virtually every outcome measure, case rates, hospitalization rates, mortality rates, we see these disparities for COVID-19. Next slide. So what's interesting as well is that we also see disparities in terms of the representation of certain racial and ethnic minority groups compared to their overall representation in the larger population. This slide it's a little bit small for you to see the writing, but I can walk you through it just the same. This is obviously a map of the United States, and those light brown to rust dots are areas where African Americans are have the highest disproportionate rate of representation of COVID-19 cases. So in other words, all of those counties that are dark brown are areas where African Americans have the highest COVID-19 rates. And in some of those cases, particularly in the Southeast, some of those counties very well may be counties that have majority Black populations, but that certainly does not account for all of them. And once you get out of the Southeast, there are very few counties in the Northeast, as well as the Midwest. You see a spattering in Michigan, in Minnesota as well, and also in Illinois. Fewer of those counties are prone to have majority Black populations, particularly outside of large city populations. So again, we see, and the lighter brown counties shows comparable areas where Latinos represent the highest case rates. And again, it's probably in many places where where Latinos are outnumbered, by other racial and ethnic groups in some of these counties. So again, you can just see the distribution geographically and in so many areas where African Americans and Latinos in particular represent the group affected most by COVID-19. Next slide. And this looks at similar data a little bit more granularly. And we're looking more at local inequities. And these are in various states and cities in the US. Actually, looking at African Americans by the percentage of population and the share of coronavirus deaths. So we'll look at Milwaukee, Wisconsin in the top left. And we can see that on the left vertical axis, they represent 26% of the local population, but 73% of the deaths. If we look at Louisiana, the state of Louisiana, similar pattern, 32% of the population, 70% of the deaths. So you can look at all of these, and even putting aside the numbers, you can see that all of these slant diagonally, with the exception of Florida, it's almost equal, slant diagonally to some degree to the right, slant upward to the right, demonstrating that the percentage of deaths is out of proportion to the percentage of the population. And the thought is that there just may be longstanding systemic health and social inequities that are putting some of these groups, and in this case, African Americans, at increased risk of getting COVID-19 and certainly having severe illness and worst of all, death from COVID-19. Next slide. So I want to bring this a little bit closer to home. We saw those, the last slide, looking at a couple of municipalities and states spread throughout the US. Here in Alabama, and this is data that is as of June 2020, when COVID-19 rates were starting to peak, where there really was a time here when there were also, I think, local efforts underway to try to better understand measures and implement measures to control COVID-19, but many of them only in the fledgling stages, and depending on where folks lived and resources available, those efforts varied accordingly. And so this is sort of a case study in health disparities, a tale of two counties. These are two counties, Lowndes County, which is the lower rust-colored county on the map, and this is a map of the state of Alabama, and then Autauga County, which is, as you can see, adjacent to Lowndes, but just north of Lowndes. Though they are very close in geographically, they actually are very different in a lot of ways. So you can see here in this table, I've highlighted some of those differences. Lowndes County is officially part of the Black Belt in Alabama, whereas Autauga County really is not. The Black Belt in our state is a reference that really goes back to the quality and, quite frankly, the fruitfulness of the soil in a band of counties in the middle part of our state that includes Lowndes County. That, because of the fertile soil available there, it also metaphorically was fertile ground for growth and flourishing of slavery, because there was an opportunity to own and run large plantations, of course, that were manned with slave labor. And so while the initial reference was to the soil, it also became a reference to the demographics of this part of the state, namely that there was a large slave population. And even now, 160 years after the abolition of slavery, many of those counties still have majority Black populations, and Lowndes is one of those. So that's just to give you a little bit of context on Lowndes County. Autauga County is more of a suburban, exurb community of Montgomery, which is our state capital. So it's largely suburban. It does have a medium-sized city by Alabama standards, Prattville, but largely rural and largely suburban. You can see the racial distribution there. African Americans comprise 72% of the population in Lowndes County, only 19% of the population in Autauga. In June, the COVID rate was dramatically different. You can see per 100,000 people in Lowndes County, it was 617. In Autauga County, it was less than 50% of that at 274. Now, as of September, those rates have evened out quite a bit. And in fact, Lowndes County may have an even lower rate now than Autauga County. And they're both around 175 or 200. I don't remember off the top of my head because it's been about a week since I looked, but that has evened out. But again, in these early stages, when local communities were scrambling, trying to figure out how to combat the spread of the virus, how to test folks, this disparity existed in COVID-19 rates. In terms of other chronic diseases or risk factors, the diabetes prevalence is higher in Lowndes County, 11.4% of the population versus 9.9% in Autauga County. The obesity difference in obesity prevalence is even more stark at 45% in Lowndes County versus a third in Autauga County. So again, just wanted to frame locally a disparity in COVID-19 rates in two counties that are adjacent to one another and begin perhaps to explore some of the reasons why. Next slide. And so again, the question begs to be asked, why the disparity in these two counties that are neighbors on the map? So when we look at the availability of primary care physicians in these two counties, this is a ratio of the population to primary care physicians. So put another way, the number on the left represents the number of people for every primary care physician, which is represented by the one on the right. So for every primary care physician in Lowndes County, there are 10,080 individuals and or residents of Lowndes County. When we compare that to Autauga County, it's almost a five-fold lower ratio. You can see the a little over 2,200 residents per every physician. So we can easily do the math here. It's much harder to get in to see a primary care physician or have access to a primary care physician in Lowndes County than in Autauga, just based on those ratios. When we look at education, they're roughly the same in terms of high school education, but then it's almost shocking when we look just at some college. So not necessarily college graduates, but just some college. We can see that they're no longer comparable, with only 35% of Lowndes County residents having some college and 62% of Autauga County residents having some college. When we look at median household income, again, a stark difference. Lowndes County at $34,000, Autauga County $59,300. To give you some frame of reference for our guest, when we have a number that we call the federal poverty line. It's the number of, it's the income annually that the federal government has identified as the difference between being poor and not poor. And that number for a household of four is roughly $23,000. So that gives you some reference here in terms of interpreting these measures of household income. Unemployment rates higher in Lowndes County, rates of uninsurance, rates of food insecurity, rates of people reporting severe housing problems, all higher in Lowndes County. So again, we see that these disparities in COVID-19 rates may not occur in a vacuum when we're comparing these two counties. There may be some other differences that potentially correlate with the differences in COVID rates, and quite frankly, may be partially explanatory as to those differences in COVID-19 rates. Next slide. So this is a pie graph that we're probably all familiar with on some level. It's based on work done by the World Health Organization, which basically shows that when we look at attributable risk of death based on certain types of factors, we find that behavioral patterns and social circumstances, environmental exposures, cumulatively account for roughly 60% of contributions to premature death. And the reason I single those out is because those are not healthcare, which is only accounts for about 10%, and where we spend obviously most of our time thinking about how we can improve healthcare. And unlike genetic predisposition, they are actually modifiable. We can't modify necessarily, at least right now, our genetics. Our genetics are what we inherit from our predecessors, but we can impact behavioral patterns, we can impact social circumstances and environmental exposures. Next slide. And these all sort of map back to some of the reasons why we may see this increased COVID-19 burden among racial and ethnic minorities. Number one, and speaking about African Americans in this context, but also Latinos, they are each group is disproportionately poor relative to whites. So what that means is there's a larger proportion of African Americans and whites that are poor compared to proportions of whites that are poor. It doesn't mean that all African Americans and Latinos are poor, nor does it mean that no whites are poor. It's just that larger shares of the two minority groups are poor compared to whites, and as a result, may be living in smaller domiciles, may be more likely to live in multi-generational households. All of these things lead to living in crowded housing conditions. They also minorities may be more likely to find themselves in working in essential jobs or public-facing jobs. So if you're working in housekeeping, if you're working in retail or other service industries, there may be no opportunity to work from home or to do something virtually. And it may require not only that you be in a work setting in person, it also may require interaction with the public, which of course statistically increases your risk for contracting COVID. There can be inconsistent access to healthcare, chronic health conditions, which disproportionately affect minorities. One of the chief examples here in the US is high blood pressure, diabetes as well, and then stress and immunity. So the extent to which the chronic stress of being in a racial or ethnic minority outgroup relative to the majority group may have some physiologic impact on individuals' immunity. It may make it harder to fight disease once exposed. So all of these may contribute to the increased COVID-19 burden, and in particular, the increased risk of severe illness among, number one, contracting the disease, and then number two, the increased risk of severe illness once infected with COVID-19. Next slide. And so a lot of attention has been paid to the next COVID wave. Is there going to be some point in the future in which we experience another dramatic rise in COVID cases? And I think there's been a lot of prognostication around that, and of course, a lot of concern. I want to talk a little bit about a different sort of wave in the next slide. And that is not so much the next wave directly from COVID, but are we going to see a wave among those disproportionately affected by COVID in terms of their other medical problems, specifically chronic disease. So COVID-19 has undoubtedly disrupted chronic care nationally. And if there were groups that were already struggling with access and simultaneously struggling with chronic disease, to what extent has COVID-19 disrupted that chronic care and set these groups up for higher morbidity and mortality, even from the chronic conditions aside from COVID? So this map is an indication of what may be a cause of that wave of chronic illness or chronic illness outcomes that we may see. It represents the percent of health center service delivery sites that were temporarily closed due to coronavirus relatively early on in the pandemic in early May. And you can see that in the darkest shaded states, 25 to 73% of health center, and these are federally qualified community health centers responding to a HRSA survey. You can see that those darkly shaded blue states are ones in the highest quartile of closures. But we can see even in the next lightest shade represents a lot. And a good number of these darker shadings correlate with areas that had the highest case rates early on and probably had the most restrictive responses in terms of public health policies. But again, it just demonstrates that these community-based health centers that oftentimes offer care in the communities where racial and ethnic minorities live, and oftentimes at affordable rates because they're subsidized by the federal government. So many of these were closed early on. And so many folks outside of these centers may not have had a place to access care. Next slide. And there also was a disproportionate impact on financial hardship. When we look at this slide from the Commonwealth Fund, we can see here that we have different responses to questions about how COVID affected persons' finances. And this is stratified by race. White is represented by the green bar. African Americans are represented by the blue bar, and then Latinos by the gray bar. So in the first question, been unable to pay for basic necessities like food, heat, or rent. Higher proportions among African Americans and Latinos responding yes to that item. Used up most or all of their savings, again, more than double. And for Latinos, triple the rate of whites in answering yes to that question. Borrowed money or taken out a loan, suffering from any economic consequence, again. Higher yes responses from African Americans and Latinos to all of these questions, which are all indicators of financial hardship. And so it raises a question again, post-COVID, or even in the midst of the pandemic, to what extent are these financial hardships going to have an impact on individuals' health? Next slide. And then there also has been a disproportionate impact on mental health. And these are stratifications by race, gender, and income in terms of respondents reporting having experienced stress, anxiety, or great sadness that they found difficult to cope with since the pandemic began. And again, for the sake of time, I'll just focus on the top group of bars. African Americans and Latinos, again, facing or reporting that they had faced greater sort of mental stress as a result of the pandemic compared to whites. Next slide. So I'd like to just quickly talk a little bit about next steps, and then I will conclude. Next slide. So we've locally in the Division of Preventive Medicine, where my academic appointment is, we've partnered with the local Department of Health, with Cooper Green, Mercy Health Services Authority, as well as UAB Health System, to do some community-based testing. One of the things that we were finding early on with testing is that sites weren't always geographically where racial and ethnic minorities could get to those sites. We also found that many of them were drive-through only. So if you didn't have access to a car, even if you could conceivably get to a site by public transportation or someone drop you off, you literally could not get tested if you did not go through in a car. So in response to that, with our partners, the MHRC launched this testing effort where sites were rotated in various places in the community, local churches, other locations that people were familiar with. And this is data for roughly 10,000 individuals that have been tested thus far in the local Birmingham metropolitan area. And you can see the positivity rates for Latinx individuals is almost 20%. For African Americans, it's about 8%. And both of those are much higher than whites at less than 4%. Next slide. And this is just looking at, it's a snapshot of community testing at a few sites in 4 different communities in Birmingham. And it just shows that we are able to reach African Americans in terms of testing. Almost 70% of those tested are African American. Roughly 23% are white. And then you can see when we, and then roughly 32% are Hispanic. Next slide. And when we look at positivity rates here, again, we see larger rates of positive rates among African Americans and Hispanics compared to whites. And we see how we're able to reach these different communities. These West End, Titusville, Hoover, and Bessemer are just different parts of the local metro. Each one has sort of unique demographics, but we're trying to reach all of these places to be able to ensure that everyone has access to testing. Next slide. New Horizons. Obviously, there's a lot of talk in the news about vaccinations, and hopefully there will be a safe and effective vaccine that is discovered and then can be widely disseminated in a timely fashion. I think it represents the next horizon and the next opportunity for us to address some of these disparities. Not that we've done everything we can with regard to coping with disparities in case rates and mortality and testing, but we also have to be forward thinking and make sure that we aren't blindsided by potential pitfalls with vaccinations. And this just demonstrates one of the areas where we've struggled with vaccinations in the past. And this is pneumococcal vaccination. So one of the main types of bacteria that causes pneumonia. We have a well-proven, very safe and effective vaccination that is generally recommended for everyone over the age of 65. However, you can see for whites in Alabama in that top ribbon, we've vaccinated about 76% of eligible whites, and that puts us right in the middle of all states. This is the ribbon represents sort of the vaccination rates for all states. We look at African Americans, however, we're just over 50%, and you can see it puts us down in that bottom quintile among other states. So again, we need to really focus and think about why these vaccination rates are so low, and make sure we don't encounter these same pitfalls when we think about COVID-19 vaccinations. Next slide. So how do we study this COVID-19 disparities better? There's some risk of the current data. We certainly can walk away looking at all these racial differences and think race equals biology. We of course know that's not true. Race is a social construct. There's nothing inherent about any of these minority groups that makes them more prone to these poor outcomes. We also have to be mindful to avoid racial stereotypes of behavior patterns. It harkens back to the turn of the 20th century in the South, where African Americans had higher rates of TB, and it was thought it was attributed to behavior, and they were often described as an incorrigible group who would not take the necessary precautions. As we look at geographic disaggregation, we have to make sure that we don't stigmatize place or create a blemish of place, namely that certain neighborhoods, for whatever reason, are hopelessly burdened by COVID-19 or other poor health outcomes, and begin to attribute those statistics to the neighborhood, as opposed to trying to tease out reasons why an individual neighborhood may be overly burdened with some of these outcomes. And then lastly, whose problem is this? We have to make sure that in thinking about disparities and in parsing out groups that are affected, we keep in mind that this is a broader societal problem. And I think COVID-19 honestly has brought that message home. Obviously, none of us is immune. It potentially can affect everyone, but we just have to make sure that we don't simply assume that because one group or multiple groups are being disproportionately affected, that it is their problem. This isn't next slide, but could you advance? And we can do some things to mitigate the risk of the current data. Advance. Make sure that we track socioeconomic data along with race data, so we can tease out the independent impact of income status from race instead of attributing everything to race. We can consider stress as a risk factor. It's oftentimes overlooked and not measured, but it certainly correlates oftentimes with race and can explain some of the differences that we see. Advance. And also highlighting the resource deficits within the place-based risks that we see. So not just focusing on the fact that neighborhood A has a higher COVID rate than neighborhood B, but then what resources are absent in neighborhood A that may be present in neighborhood B. Next slide. So Martin Luther King was prescient about, honestly, probably innumerable things in his lifetime. But toward the end of his life, he began to pivot a bit, not abandoning civil rights, but to talk about other aspects of life that warranted attention that were closely related to civil rights. And healthcare was one of them. Obviously, income equality was one as well. And he said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And though he was obviously assassinated in 1968, that still holds true today, now over 50 years later. And I think that it's incumbent upon all of us to think about this and try to figure out ways in which we can address these many, many examples of inequity and quite frankly, injustice in healthcare. Next slide. So I'll stop there. I know I went a little bit over. I know you all have a very regimented schedule, so I'm happy to take questions if there's time. If not, I certainly can make my contact information available if need be, if individuals want to reach out to me directly. So I'll defer back to Dean Pawlowski.
Okay, thank you so much, Dr. Durant. That was fantastic. I'm going to stop sharing unless there's a slide that you would like to go back to. But I think that you've highlighted some just critical issues that our country is facing. I'm interested to hear from our colleagues in Ghana as well, particularly regarding the challenges of chronic disease and the impact on infectious disease, and of course that challenge of the health disparities that we see. So thank you very much for your presentation. So I'm going to open the floor. You can, if you are too shy to speak up, you can put a question in the chat room. But I think we have a few enough people here that anyone can just, by the way, Dr. Durant, we are streaming this live on YouTube, but we're not able to get those questions, only the Zoom questions. So if any of you have some questions, please go ahead.
I'd like to thank you, Dr. Durant, for your excellent presentation. I just wanted to highlight one thing personally about Lowndes County. Your statistics were correct. They only have one physician in the entire county, which makes it difficult for things like COVID and other health disparities. So I just wanted to put a sort of face on it, how difficult it is for some of our rural areas as far as access. And the second question, the cytokine storm you talked about, I had never heard that term. So I know there's a lot of discussion since this is a new coronavirus about long-term effects of the virus. And maybe that has something to do with what you were talking about with cytokine. Could you talk a little bit more about that?
Sure. So my disclaimer is I am neither an immunologist or an infectious disease expert, but I will tell you what I do know. So cytokines are substances that play key roles in our inflammatory responses in our bodies. So oftentimes when we have infections, or if we are exposed to some allergic stimulus of some sort, cytokines can help trigger the pathway that helps us develop an immune response, or in some cases, much to our chagrin, an allergic reaction. And oftentimes, actually, they are targets. They serve as targets for medications, particularly if those allergic reactions are harmful to us. There are a whole host of medications that actually target these cytokines, but when they are produced in great amounts, it basically can overwhelm the body and create bad things. We can have difficulty with clotting. We can have heightened inflammatory responses in the lungs that make it difficult for us to breathe. So the cytokine storm really is an acute response to the virus, and it's very difficult to combat it once it starts. The healthcare providers that are taking care of these patients basically can only provide supportive care, and oftentimes it's in the form of mechanical ventilation, so hooking someone up to a breathing machine to help them, hoping that they will get through the cytokine storm and the effects of the cytokine storm in order to recuperate. In terms of long-term symptoms, it probably doesn't play as much of a role in long-term symptoms, but you correctly alluded to the observation that we're finding that large proportions of people are having long-term symptoms from COVID-19. The one most frequently cited is fatigue, and may be lingering for weeks in over 40% of patients who have COVID-19, at least here in the US.
Thank you.
Sorry, may I just ask a question on what is your, I'm sorry, I'm Richard Apatu from Ghana. I just want to find from you, what is your take on the fact that it appears that in Africa, the mortality rate is not as high as we feared? Are there some aspects that you found in America which could maybe explain that aspect in Africa?
Yeah, so I have to plead ignorance on the infection rates across the continent of Africa, or even within individual nations on the continent. I probably go back to some of the factors that that I highlighted earlier that may make minority groups here more prone, and quite frankly, make Americans on the whole more prone. There may be more population dense centers in the US in relative, I recognize that there are plenty of those in many African nations, but numerically, there may be more of them in the US, which has led to higher rates. I think that, and I've talked, and this is more conjecture. There is a line of thinking that our country, perhaps our country's greatest strength, so our country's greatest strength for many would be our freedoms that we enjoy here. And it's not just the freedoms protected in our Constitution, but it's also, in general, we don't have much interference in our daily lives from any authority, whether it's government or any other authority, by and large. And that ethos may have set the stage for some of the struggles that we have had with COVID-19. In general, and again, this is conjecture, so this is me being amateur sociologist, so take it for what it's worth. In general, in this country, we are not accustomed to being mandated to do something. There are a few things that we do. We pay taxes. That's really probably about it. We don't all do that. But I think that in other countries, there are typically other contexts where citizens have been asked, or in some cases mandated, to do something. And I wonder if in some nations, and again, I don't know if this is true of African nations as a whole or any individual African nations, if that led to early on more adherence to guidance from federal government.
Well, just to add to that, one of the things to Dr. Apatu's question, this is Thad Olsen, the CCHS in Alabama. I've been looking at the Ghana data, and one of the things I found, Dr. Apatu, is that the asymptomatic rate in Ghana was as high as 90%. So it made me wonder if the population in Africa at some point has been exposed to some variation of this virus. And because the asymptomatic rate in the US is somewhere between 30 and 45, which speaks to the fact that many of the patients in Ghana are just who test positive, 9 out of 10 are asymptomatic. And then, but when you look at the data, the mortality from the few that get it in Ghana is quite high. It's about 50%. So if you do get sick there, chances are you're not going to make it, but chances are you're not going to get sick. So that's, so,
Can I throw something else in?
It's not the whole story, but distinctions in testing rates may also account for some of that. I don't know how widespread testing is. Again, I'm not suggesting that that's the only thing.
Yeah.
And the other theory is that the populations in Ghana and Africa are younger.
Go ahead, Pam.
Yeah, I was going to say the other theory is that the populations in African countries are younger, much younger, may play a part in some of the things we're seeing between the two countries. Yeah.
And one question that I was curious about is you're measuring the rate of chronic diseases and the connection with chronic disease and COVID-19, and something that I've been working with geographers looking at more from a very large scale geographic perspective as to the prevalence of COVID cases and deaths that correlate very significantly with areas where there's high rates of morbid obesity. And in Ghana, you're not going to see necessarily those high rates, which of course would associate with chronic diseases too. So that I would think.
Exactly so. Looking at the issues of nutrition, as you rightly mentioned, that obesity is a key factor also within the causal, the closely related risk factors of this COVID-19 situation. And relatively looking at obesity in these two regions, we find it quite on the high side, looking at those in America as compared to the prevalences we have within our country. Besides, the other aspect, I don't know, some work I'm just looking at was talking about vitamin D exposure, which basically I was having a chat with a colleague concerning some of these situations, and the issue that came up was the fact that, yes, of course, when we look at the Black population, our exposure to vitamin D compared to the white population is quite low in terms of exposure and then getting the vitamin D. And that possibly may account for the fact that we have quite a lot of the Black populations within America having some of these conditions as compared to the white situation, of course, because we've seen some health benefits with some of these vitamins. There are many other issues which nutrition issues have come up. And besides, I wanted to find out what about the homeless population? I mean, the risk within the homeless population within these regions. I mean, looking at exposure, possibly if there is any connection with the data that.
Is there any way I regulate my end so I mute most of the time, else I'll disturb the the proceeding. Now, from also you mentioned something about chronic diseases. Is it postulated that the similar kinds of viruses will give some form of immunity against infection of the coronavirus?
Well, just because of the high asymptomatic rate, it suggests that the population could have been exposed to a virus that was similar enough to provide some level of immunity, even though you get infected. And I think the asymptomatic rate across West Africa has been pretty high. I know that Ghana is about 90%, and so there's a question of, is there some natural resistance, quote unquote, because of prior exposure to some other coronavirus that may not have been as, pathological in terms of causing symptoms, but offering some level of immunity. I mean, the data is still coming in, but it's very interesting that the asymptomatic rate in Africa is very high. And Dr. Durant was asking about testing. I think testing in Africa has been quite rigorous, and Dr. Apertu, you may speak with this, because because the African countries have just been following the WHO protocols and have been doing that. We haven't left the WHO, so we've been doing that, and so the testing has been pretty rigorous and pretty regular. In Ghana, they've been using pooled testing across the country to do this. So, but that asymptomatic rate difference to me says something, because it's been fairly consistent. I have a colleague in South Africa as well who says the finding there is also that the asymptomatic rate is above 80%. So people are getting the infection, but they're not having a lot of symptoms. And like Dr. Foster said, it's possible that demography may be part of it. Africa is a very young continent, but it's probably a combination of a number of protective factors that have come together. Yeah.
There was a question about homelessness. I think one of the professors mentioned. I know it is a risk factor. I don't know, Dr. Durant.
Yeah.
It is, and it certainly is a contributor in part to some of the higher rates that we see here in the U.S., particularly in our cities, where just numerically speaking, much of our homeless population is concentrated.
Well, I know we are hitting the 5:00 p.m. mark in Ghana and the noon time here in the United States. So, I'm happy to stay on, but I know Dr. Durant, you have, I'm sure, are busy. This was fabulous to hear about your research. It shows, unfortunately, the great number of challenges that we have to delve into, particularly here in Alabama, but obviously globally too. And in the next couple of days, we're going to be hearing more about social determinants of health, as well as looking at gender, race, and the memory of the slave trade. And obviously those can impact as determinants of health, as you shared in some of the county reports. So you're welcome to participate and join on the rest of the meetings. We'd love to see you there. I know you have a busy schedule, but thank you again so much for sharing, and we really appreciate this important presentation. So if that, I will stay on if others have want to discuss, but again, thank you. I don't want to take up all your time today.
Thank you all for having me. Thank you, Dean Pawlowski. Thank you, Dr. Payne Foster. It was my pleasure to address this group, and would love to hear more about what you all are doing as a partnership. It sounds really fascinating in terms of some of the things that you all are discussing as sister institutions, somewhat on different continents. So my hat goes off to you all as well. Thank you.
Wonderful. Thank you so much. Right.
All right.
Okay, bye-bye. Well, thank everyone. Thanks to all for being here, and you're welcome to leave. I'll stick around for a couple minutes just to let you know, tomorrow we're going to start off a lot of the faculty presentations, and then we'll end with social determinants of health on Thursday, and we'll have a keynote speaker who's going to be talking about some of the issues related to HIV/AIDS, but we're going to be hearing about issues in Ghana as well as here in Alabama. So again, I thank you all for your participation and joining us. I know there's been some technical challenges today, but I think we've resolved some of those, so it'll be easier to join tomorrow. So again, I put a website up on the chat room, so you can go to the Ghana Partnership website to get more information on our partner institutions here in Alabama, as well as in Ghana, and then see the detailed schedule. So you all have a great afternoon and evening in Ghana.
And bye.
Bye.